Welcome everyone to today's Serving Access and Functional Needs Populations in Times of Disaster seminar on Medical Reserve Corps and Community Partnerships. First, some quick introductions. Myself, I'm Trey Brook. I'll be your lead facilitator for today, along with Jessica Driscoll, our co-facilitator. We're also happy to have on board today for today's seminar, Association of Bay Area Health Officers Representatives Ava Holt, Teresa Boone, and Daniela Poy-Wing. And some quick comments. I'll turn it over to Jessica for some opening remarks.
Welcome, everyone. Thank you for joining us. Some quick opening remarks. This MRC CBO seminar was recorded originally on December 4th. Unfortunately, we did have a glitch with Zoom. I guess they have that glitch a little more frequently than they would like to admit, but we lost part of our recording. So this is a re-recording. So you'll only see Trey and I on the screen today. So there will be no audience for the first 43 slides. Then we transition over to the original recording that actually recorded for us in Zoom. And this is where you'll see more members of the team in the window. You'll also be switching from the Teams format to the Zoom format at that time. So it'll have a little different style in the video itself. And you'll see more interaction at that time as well. And our panel members, we're really excited that our panel members and all the things that did saved for us, because a lot of what we're doing is just talking through some important topics here in the beginning, and there's not as much engagement. These originally the opening remarks were done by Ava Holt, which we really appreciated. And what she talked about is the importance of MRC volunteers, so the Medical Reserve Corps volunteers and community-based organizations and their partnerships within an emergency. We use these volunteers in the Medical Reserve Corps for several different things that we'll be discussing in more detail today. And we also use CBOs in a lot of different ways throughout disasters. And we want to give you guys the opportunity to just learn some basic emergency management principles today. So it is a little higher level seminar, just talking about some of the basics, whether you are brand new and these are new concepts, or maybe you're more experienced emergency manager, or you've more experienced MRC or CBO within emergency management, and it's just a little bit of a refresher course. This MRC and CBO seminar is sponsored by the Bay Area UASI Funding for Community Preparedness Initiative. So we're really appreciative for the Bay Area UASI to support us. I am Jessica Driscoll. We are with Constant Associates. We are a third-party contracting firm who is supporting today's seminar. So you'll see myself and Trey in these first 43 slides, and then you'll see some other team members jump in the other recording. I will hand it back over to Trey to go over the seminar objectives. Thank you, Trey.
Great, thanks, Jessica. So on that note, for today's seminar, we have the objectives that you can see on screen, starting with introduction of foundational principles of emergency management. Shortly, we're going to do a quick knowledge test, as we did in the original seminar, just to kind of take a pulse check of foundational knowledge, which helped feed into the conversation later in the original recording. But that was our first introduction to information about emergency management and what that looks like, together with national frameworks and state frameworks. Also clarify the procedures for activating and deploying the Medical Reserve Corps, including coordination protocols, triggers for operations, and role expectations. Also, strengthen coordination between the MRC, community-based organizations, and access and functional needs partners, which is the core of today's seminar content that we were discussing, is how we coordinate and best serve those populations during a disaster. We'll also explore tools and templates that support preparedness, including go-bag checklists and guidance for access and functional needs. And finally, engage in open dialogue through question and answer. We have some great panelists that you'll see shortly within the seminar who are going to exchange some lessons learned and provide some advice on how we can further the goal of coordination as organizations. Schedule for today, again, with the original seminar you can see on screen, starting with that pulse check. Then we'll talk about those emergency management fundamentals, moving on into access and functional needs integration in emergency management. Talk about roles and responsibilities. We'll discuss Medical Reserve Corps and CBO coordination. Then we'll talk about coordination strategy, communication strategies and tools. Then you'll see that panel discussion that I mentioned with Q&A and an opportunity for some dialogue in that segment that we originally recorded, and then wrap up with the hot wash and next steps for today's seminar. So starting with the pulse check, I'm going to go through this rapidly again. As you understand, in the original recording, we did do this pulse check. These are the questions that we asked the original attendees of the seminar, starting with, how familiar are you with emergency management principles, mitigation, preparedness, response, and recovery? The original group that participated and attended in this to this event responded kind of a variety of different answers between not so familiar, somewhat, or very familiar. So kind of a mixed crew that we had for the original seminar recording. Our next question was, had they participated ever in EOC activation or emergency response? We had, again, varying answers there from never all the way through many times. We did have several people respond that they had at least been involved a couple times in EOC activations, and yes, several people did indicate that many times for those who had been involved in the field for some time. Next question was how confident participants were in explaining the difference between Medical Reserve Corps and community-based organizations. Lots of good feedback here. Folks were generally only somewhat confident in kind of the middle average of responses there. So definitely this seminar is for those who need to explore those concepts, especially as we talk about the next element, which is how familiar were participants with the term access and functional needs. Again, a range of responses there, but not deep comfort with being able to explain what that means and what all that involves. Again, that's the core of what this seminar is about how Medical Reserve Corps and CBOs work with those populations, which we're going to explore in this seminar. And then lastly, how often did participations organizations collaborate with public health or emergency management agencies? Lots of responses there, regularly, and often. So lots of different responders in the original participation to the seminar who indicated, yes, there is a robust coordination with those different entities in their communities. Moving on then into emergency management fundamentals. This is where we will cover some of the basic concepts of emergency management, starting with a basic question. What is emergency management? So emergency management is really an organized approach, a framework that communities use that deals with risk management, preparing for threats, and responding to disasters. It provides a structured approach to be able to coordinate together to protect people, property, and essential services during and past an emergency. What's the importance of emergency management? Why do we engage in that framework? Because these things can happen anytime, anywhere. Disasters and emergencies of all different kinds of proportions and natures. They can affect individuals, families, and whole communities. And we know, just from a proactive perspective, that being prepared, organized, and connected will improve outcomes. And that's the heart of why we engage in emergency management. And then finally, we know that emergency management systems help us respond effectively and recover faster. So when that alert goes off, are we maximally ready to respond to the crisis and recover after the fact? The four phases that we have in emergency management you can see on screen include mitigation, preparedness, response, and recovery. Mitigation, in short, are the actions that we take to prevent or reduce the impact of disasters. That includes both structural measures like levees, fire-resistant building codes, and so forth, and non-structural measures like hazard mapping and land use planning. The goal is to minimize loss of life and property. Moving on to preparedness, these are activities that we carry out in advance to ensure an effective response when disasters do occur. That includes developing emergency plans, training our personnel, conducting exercises, stockpiling resources, and educating the public. When we do go into response, these are the immediate actions that we take during or just after a disaster in order to save lives, protect property, and meet basic human needs. This might involve firefighting, search and rescue, evacuation, emergency sheltering, and emergency medical care. And then lastly, recovery. These are the efforts to restore normalcy after the immediate threat has passed. That includes rebuilding infrastructure, restoring services, providing mental health support, and implementing lessons learned to improve future preparedness and mitigation as part of the overall cycle. Some of the frameworks that we work with constantly, and this is throughout the state of California and nationwide, starting with that level, we start with the National Incident Management System. This was established by the Homeland Security Presidential Directive 5 years ago to unify federal, state, local, tribal, and territorial coordination. This integrates incident command system methodologies to ensure a nationwide consistent approach. Next, as mentioned, the incident command system itself. This is the core operational system under the National Incident Management System. It offers a scalable, all hazards approach for incident management with clear roles and defined authority lines. Next, in the state of California, we have what's called the Standardized Emergency Management System. This was mandated in California in 1993 under the Emergency Services Act. This organizes response across the field, local operational areas, regional and state levels, requiring incident command system use at the field level. So the National Incident Management System is the national framework, incident command is the operational method, and the Standardized Emergency Management System is California's specific application to align with the National Incident Management System while meeting state requirements. Next, a quick intro on what is the Emergency Operations Center. So the EOC, or Emergency Operations Center, is essentially the nerve center of response and recovery operations. It's not where field response happens directly. That occurs on the ground with the first responders. But the EOC provides the strategic and logistical backbone that supports those operations. Think of it as the coordination hub where representatives from multiple agencies, public health, law enforcement, fire, EMS, social services, and even community-based organizations come together to manage the broader picture. The EOC's key functions include establishing situational awareness, which is gathering and synthesizing information from the field to build a shared understanding of what's happening. Also, setting priorities and allocating resources. This ensures that the right help gets to the right place at the right time, especially when the needs exceed local capacity. Also, coordinating across jurisdictions and disciplines. This links cities, counties, and sometimes states or federal partners for unified response. And also providing information to decision makers and the public. Through the joint information systems or coordinated messaging teams, we accomplish that. During activation, the EOC operates within a structured system, usually aligned with SEMS here in California and NIMS nationally, to maintain clarity in roles and communication lines. It's also important to remember that the EOC is staffed with subject matter experts who support incident command in the field. So if, for instance, a shelter is running low on medical supplies or staff, the EOC facilitates that resource request, tracks it, and ensures accountability. For Medical Reserve Corps and community-based organizations, understanding this structure is crucial because it shows where they plug in during a real-world event. When your organization provides field support, like staffing shelters, conducting outreach, or delivering supply, the EOC serves as your primary coordination and reporting link. This ensures every effort aligns with official operations and avoids duplication. For EOCs, from local to federal, the key message here is that disasters start local. Every incident, whether it's a wildfire, earthquake, flood, or public health emergency, begins with local responders, city and county agencies who are the first to act. The local EOC is often the first to activate. It coordinates response within the city or the county, bringing together departments like public health, public works, police, fire, and community organizations such as the MRC and CBO partners. Once that local capacity starts to get stretched, coordination naturally escalates upward. Here's how that escalation works. At the local level, the city or county EOC manages the on-the-ground situation, deploying resources, tracking impacts, and making resource requests for support. For example, during a major power outage or sheltering operation, the local EOC might call on MRC volunteers for medical support or partner with CBOs to reach vulnerable populations. At the regional level, the Regional Emergency Operations Center, or REOC, supports and coordinates across multiple local EOCs within a geographic region, like the Bay Area. Their role is to make sure that local jurisdictions aren't competing for the same limited resources and the communication is consistent. For example, if two neighboring counties both request medical staff, the REOC helps prioritize and deconflict those requests. At the state level, the State Operations Center, run by Cal OES here in California, oversees the statewide picture. It manages policy level decisions and allocates state resources. This is also where coordination happens between sectors like transportation, public health, and emergency management. The State Operations Center may also initiate mutual aid requests, deploy task forces, or facilitate federal assistance. And finally, at the national level, at the top, the National Operations Center, managed by FEMA and the Department of Homeland Security, monitors incidents across the country. They step in when disasters exceed state capacity, coordinating federal assets such as funding, equipment, and specialized teams. For example, during large-scale events or hurricanes, wildfires, FEMA might activate federal urban search and rescue teams or provide public assistance funding. So this structure ensures that response efforts scale efficiently. You always start at the lowest level possible and build upward only as needed. For our MRC and CBO partners, this slide reinforces where you fit into that escalation process. You'll always begin by working through your local EOC or public health department. But as the incident grows, your coordination and reporting might expand upward, sometimes providing situation reports that reach the regional or state level. The key takeaway: every level has a role, but local coordination remains the cornerstone. And by understanding this hierarchy, you can better anticipate where your efforts connect with the broader emergency management system. Quick question that we put to the group during the original seminar: how many of you have worked through a local activation where your county coordinated with the region or the state? And what did that look like in practice? We got a lot of good responses in the chat during the original recording about those who had been involved in incidents past, their role in connecting with the EOC and providing on-the-ground support for medical reserve response and coordination of community-based efforts, especially to assist with those who needed that help from socially vulnerable populations and those with access and functional needs. Moving on to the EOC and how that connects to field operations. So the question is, how do they work together? How do they coordinate during a disaster? They are really two sides of the same response effort. On the left side, we have field operations, which represent on-scene response, the people physically at the incident site helping the community. These include our first responders, firefighters, law enforcement, EMS, and public health teams, but also volunteers and organizations like MRC and CBO. They're the ones providing direct assistance, running shelters, conducting health screenings, supporting evacuees, or delivering critical supplies. Field operations are all about saving lives, stabilizing the situation, and protecting property. They execute the tactical side of the response using established emergency plans and ICS roles on the ground. Examples include shelters, medical clinics, or evacuation routes, anywhere where first responders are physically engaging with the affected populations. On the right side, we have the Emergency Operations Center. This represents off-site coordination. EOC staff don't operate at the scene. Instead, they work from a safe, centralized location, usually a county or city EOC, to coordinate support and resources. Their focus is on organizing information, setting priorities, and making decisions that enable those in the field to do their jobs effectively. The EOC ensures that responders have what they need: supplies and logistics, situation reports and intelligence, policy guidance or approvals for resource requests, and access to mutual aid or state-level assistance if needed. A great way to think of this relationship is like a two-way communication loop. The field reports what it's happening, conditions, needs, and challenges, and the EOC takes that information, analyzes it, and provides the resources or decisions required to keep operations moving forward. Then updates will flow back to the field, keeping everyone aligned. For MRCs and CBOs, this connection is especially important. When you're deployed at a shelter or a clinic, you might be the first to identify unmet needs. This might be a shortage of medical supplies or accessibility gaps for people with functional needs. Rather than solving those problems independently, your communication goes up through the EOC chain, often through your unit coordinator or public health liaison, so that those issues can be addressed systematically. Our next element deals with access and functional needs and how we integrate those into emergency management. So first, to understand what we're talking about, with access and functional needs, we're referring to anyone who may need additional help to receive and act on emergency information, evacuate safely, access shelter, or receive medical care. These needs are not limited to disability status. They include communication barriers, isolation, and socioeconomic vulnerabilities. California law, under Governor's Code 8593.3, and FEMA's whole community concept require emergency managers to plan for all residents. Integrating access and functional needs is not about special treatment. It's about equal access to safety and recovery. Past incidents, for example, the Palisade fire and COVID-19 response, revealed severe disparities in outcomes for people with disabilities and language barriers. Integrating access and functional needs makes plans more comprehensive and adaptable for everybody. MRC and CBO are key connectors. They translate emergency guidance, deliver targeted outreach, and maintain trust with marginalized groups. Inclusive practices like sign language interpreters and briefings, translated text alerts, and sensory-friendly sheltering spaces are not optional. These are the best practices that save lives. And I'm going to pass back over to Jessica Driscoll, my colleague, who is going to discuss a real-world example from 2018 to shed some more light on coordination between MRC CBO and especially working with populations with access and functional needs. Jessica?
Great. Thank you, Trey. I'm going to go ahead and take over control of the slides. So everyone should be able to see my screen. Hello, everyone. I am Jessica Driscoll, back with you again. I am a senior associate here at Constant, but in my previous life, I was the emergency manager for Butte County Public Health, just north of y'all in the Bay Area. I'm sure many of you know, and I recognize some faces that were on the seminar that were actually there in the trenches with us during the 2018 campfire. So we're going to talk a little bit about MRCs and the utilization of MRCs within that response, as well as CBOs and the relationships that we had with CBOs, and then also access and functional needs and how to ensure that the whole community is being taken care of in a shelter population. So on this slide here, one thing I really want you to pay attention to are the pink binders. We use these pink binders to help support our MRC members in the shelter response. So I'll touch on these a little bit here soon. All right, so if you are unaware of the 2018 campfire, it was up in Butte County on November 8th of 2018. It destroyed almost 19,000 structures and displaced really quickly 52,000 plus residents, including multiple healthcare facilities such as skilled nursing, assisted living, and other long-term care homes, because there was a large population of those homes up in the Paradise area. We also had one hospital that was fully evacuated. So as you can tell, there's a lot of things happening, and it was all very quick. In Butte County, we also had members of our team who were not able to help us in our Department Operations Center, or DOC, which I will be mentioning a lot today, because they were also evacuating their friends, families themselves from their homes up in Paradise. So you'll see a lot of that happening within this case study. We had approximately 15,000 evacuees to support across just the county operated shelters. There were 10 plus shelters, which included some ad hoc sites as well. So lots of different things happening at different shelters and different responses happening, but about 15,000, or I'm sorry, 1,500 at our peak during the campfire evacuation. We had our Department Operations Center for Public Health. We were staffed under the medical health branch of the EOC. So Trey talked a little bit about the EOC, and we were a small portion of that. We were supporting with nursing support within the shelter operations, logistics, especially around medical and health supplies, and just overall planning functions. A lot of making sure people were evacuated the day of, helping make sure that we were tracking patients the day of as well, and then making sure we were staffing those shelters to bring people in from everywhere. We had an immediate activation of shelter assessment teams and volunteer call down lists. We could tell within the matter of hours that we needed support from our nearby mutual aid regions. Going into Region 3, which is the Butte County region first, but then we quickly pulled from other regions throughout California. Bay Area UASI region is Region 2 primarily. And so that Region 2 were some of our biggest supporters. That's why I recognize some people who were on this original seminar. We could not have done it without our different groups that were there that day. So we had partners from California Medical Assistance Team, I believe is the CalMAT team. That was something that was put together through the Emergency Services Authority of California. We had the Disaster Healthcare Volunteers, which is another volunteer group. In Butte County, we're very small and rural, so we do not have the typical MRC setup. We have a DHV volunteer registry. So Disaster Healthcare Volunteer Registry, these are people who are pre-vetted in the medical field to support us that we were able to pull from. We also had our medical health operational area coordinator program and nearby healthcare coalition partners that were supporting us in our shelter response, where we pulled from other healthcare systems, as you can see Ampla Health on the screen. Also our CSU Chico nursing faculty and students were very helpful during this response. We had Red Cross who was there to support us as well from all over California and eventually the nation supporting this. And then those MRC partners. The MRC volunteers were primarily deployed to the shelters to provide medical screening, some chronic care, a lot of insulin dependency, and emotional support as we were looking at the medical health part of sheltering. Now, you see a lot of different needs within a shelter response. There is a stat somewhere that I believe says 20% of folks who show up to an emergency shelter have access and functional needs. Although that may be true within the first hour or 2 hours, quickly within the first 24 hours, I would like to debate 80 to 90% of the people who are in the shelter have some type of access or functional need. They really just need additional support and coordination and continuity of care. The one thing I also want you to remember is people who are in the shelter system are not necessarily folks from healthcare. They're not in these assisted livings. People who were in assisted livings went to other sister facilities or other assisted living cares. These are people who lived individually at home on their own. But when they were at home on their own or with their caregivers, they had caregivers. They had their durable medical equipment. They had their assisted devices that they need. A lot of people were displaced without those devices, medical equipment, their medication. I cannot tell you how many times people they left their prescription at home and they take a little white pill. That doesn't tell us much. We need to bring in our partners and make sure we have support. This is where we also had some support through different CBOs that were working with us. These CBOs worked with these populations before and were able, maybe they already had a list of their prescriptions that they were using. Maybe they had just a little bit more knowledge of what that person's condition was to help send them to a new doctor to make sure they can get the right prescription. Because in the area we're talking about, we also had their healthcare facilities with their prescription information and their pharmacies burned down too, all in one day. So there was a big lack of resources in trying to figure out what we needed. This was an extended operation lasting 85 days. So we had Veterans Day, Thanksgiving, Christmas, New Year's, Martin Luther King holiday. We also had to take into consideration our county staff was fatigued. Our MRC members who were coming in and supporting us, our team members who were there in those shelters were beginning to really have fatigue, and we were having major resource strain, not just in Butte County either. That strain was really felt in several other regions around us. We also had high transmission of norovirus during the shelter response, which one minimizes your staffing resources, and two ups the level of skills and care that is needed in those general population shelters. So MRC members really helped implement isolation areas, sanitation procedures, education for evacuees and staff. Some of the education included proper food handling, overall just disease transmission, making sure people were properly washing their hands. I mean, I think we had MRC folks who were standing at the hand washing stations at one point in time, just making sure people were washing their hands. So a lot of infection control was included, continuing medical monitoring, and just overall access and functional needs support, more access and functional needs support when there's norovirus. I may not need assistance to the restroom on a regular basis, but when I have norovirus and my body is completely without nutrients in the day, I may need someone to help walk me to the restroom. So as you think about that, those access and functional needs level really goes up as well, which means more staffing. MRC members were very supportive, helped us with insulin, overall medical monitoring, making sure that we had those proper sanitation procedures, making sure we were able to staff isolation tents, because this was also flu season. So we had a respiratory tent for isolation, and we had a gastrointestinal isolation tent, because we had two different things happening at the same time, and we were trying to make sure people were not cross-contaminating each other as well in those isolation areas. Very important, but takes a lot of staffing. Some key outcomes and just overall lessons learned were just rapid deployment enabled immediate medical and health services. We knew right away, and thank goodness we had an amazing director of nursing in Butte County, and she immediately said, we need more resources. So I served as the medical health operational area coordinator at the time. We started putting those mutual aid resources requests in. We had a lot of team members who were supporting us with those infection control protocols. Those pink binders that you saw gave a lot of information, and a lot of those MRC members helped us develop those procedures and protocols in real time. So that was just an amazing resource to have. We also just had compassion, flexibility, and endurance overall for maintaining care and quality throughout the 85-day mission. It was a long response, but we could not have done it without our MRC and our CBOs and other healthcare partners within the area as well. So if you were there, thank you so much. We really appreciate you. If anyone has more questions about this response, I'm happy to answer it for them. I'm going to jump right into some roles and responsibilities, because as you guys have already heard, it is acronym soup when you talk about emergency management. So let's talk through different roles, responsibilities, and what some of these acronyms even mean. So we have our local emergency managers. Our local emergency managers really are that backbone of the emergency response. They are sitting usually in that county EOC and supporting managing resources. They're also doing this before, after, or during and after. They are also supporting emergency plans in their area as well. So a preparedness effort, as you saw on Trey's little diagram, we have preparedness before response. And then they also lead risk assessments, trainings, coordinate some of that public outreach, and they help partner with Medical Reserve Corps, community-based organizations, and other stakeholders. So really serving as that that backbone when it comes to managing resources and communications between agencies during a response, and serving as that bridge between government, first responders, and the public, ensuring that really everyone knows their roles and has the tools to respond effectively. That's a little bit about the role of the local emergency manager, even though it's way beyond what I can tell you in this brief seminar. There are so many different things that emergency managers do, and we appreciate them so much. All right, let's talk about California State Emergency Management. So we have the SIMS system, the Standard Emergency Management System in California. In California, we like to do things a little bit different than we do in other states. So that is particular to California, or unique for California. We go from local disasters to that regional aspect to the state. So the role of the state emergency management is really they step in when that local capacity has exceeded their limits, and then the regional as well. The SOC, or the State Emergency Management, so the State Emergency Management, they are operating through the SOC, the State Operations Center. On top of that, we also have CDPH and IMSA. They operate through their Medical Health Coordination Center. So it does get a little complicated, but how I told you I was in the Department Operations Center for Butte County, think of the MHCC as the state's version of that Department Operations Center, just at that state level. They coordinate with cities, counties, and tribal governments, making sure that there's more of that unified state picture. And then they maintain and accelerate services when the demand is high. Think of COVID and how they stepped in to ensure that we were receiving support when the local and regional capacity was already exceeded. And also there were different resources coming in at the state level that needed to be managed as well. So this support includes coordination, resource sharing, sometimes directly taking over certain functions. The state ensures that local agencies know what resources are available through the state and the feds, and help them access and use these efficiently. So think of the state as the next tier of support, ready to step in when local government reaches its limit. And then the federal government. The federal government is really the last line of support in emergency management, stepping in only when both local and state resources are overwhelmed. Really setting the national standards and regulations, ensuring consistency across the country. Now, a lot of people hear emergency management, they think FEMA is the only one that we are working with. We're talking a lot about the medical health operational response as well. So the CDC comes in and supports as well, providing that technical guidance for disease surveillance, public health resources, especially for access and functional needs population. ASPR, the Assistant Secretary of Preparedness and Response, supports public health emergencies, medical surge, and healthcare coalitions, and a lot of preparedness activities that you see in the public health departments across the state. So the federal role is more about strategic support, funding, and capacity building rather than being the first boots on the ground. And like I said, we are going to have lots of different acronyms thrown at you. So here's a few of them, and I'm doing my best to remember them as we go through. You may have heard a familiar term, and this was actually, I think, started with FEMA, is the roles of the whole community. The whole community means each and every person who lives in a community, no matter where they're at that time. So some key partners will include individual residents, neighborhoods and communities, volunteer organizations such as the Community Emergency Response Team, the Medical Reserve Corps, those CBOs, private sectors, and local businesses. Really, this concept just means emergency management is not a government responsibility. It requires everyone's involvement. Individual citizens prepare themselves and their families. Communities build those local resilience and communication networks. Volunteer organizations bring specialized skills, manpower, and resources. Private industry provides critical infrastructure, supply, technical expertise, and early engagement ensures a coordinated and timely response when disaster strikes. All right, let's talk a little bit about other agencies that support emergency management. I know we see law enforcement on a day-to-day basis, but during an emergency, their responsibilities include keeping that public safety, security, and order during the emergency. Things that they might be doing are securing disaster sites, controlling traffic, and managing evacuations, protecting property, enforcing curfews, preventing looting, assisting with search and rescue, and supporting emergency communications, providing that crowd control at shelters and distribution points. I know we definitely use them at the campfire shelters. I'm sure you saw them out there if you were part of that, or other shelter responses. Now we have fire. They're first responders providing life-saving services. So in an emergency, they are conducting fire suppression, search and rescue. Hazardous materials response falls under fire as well. They provide medical care, triage, transportation of patients, supports evacuation operations, and assists with damage assessments and scene safety. They also may help with repatriation once people are able to go back into those areas. Now, I've talked a lot about public health. This is one that I could talk about all day, but I'll keep it brief for you. Public health is protecting the health and safety of the community with a focus on the medical and public health impacts during the emergency. This can include disease surveillance, control of infectious disease, and health advisories. So when you see those health alerts, health advisories, those are most likely coming from your public health department, signed by your health officer. Overseeing mass vaccination or medical dispensing operations. If any of you have heard of a pod, those are usually ran, this version or the medical pods are usually ran by public health departments in California. Supporting medical sheltering needs and continuity of healthcare services, making sure people still have care available to them in the communities. A huge portion of what we did during the campfire, because all the healthcare facilities burnt, so we had less healthcare providers available, we had less pharmacies available, we had less care homes available. So making sure that we could have that continuity of healthcare in surrounding regions in a very high capacity healthcare system already. Also advising on public health measures like a boil water notice, air quality alerts, and sanitation. Medical, so EMS provide, so emergency medical services or EMS provide that pre-hospital medical care and patient transport during emergencies. They deliver that advanced life support or ALS and basic life support BLS care in the field. They conduct triage, stabilization, and transportation of injured or ill patients to the appropriate medical facilities, or sometimes between medical facilities. They coordinate with the hospital's public health and emergency management for patient tracking and surge management. We worked very closely with them the day of the campfire as we were evacuating patients and moving them from healthcare system to healthcare system. They did a lot with the patient tracking for us. Supporting shelter medical care operations and assisting with special needs or access and functional needs populations, and just participating in mass casualty incident operations and decontamination when required. EMS often helps support us in many different ways at mass vaccination shelters, mass vaccination clinics, and shelters. Now let's get to the important people who are on this call. The Medical Reserve Corps. This is a national framework of more than 300,000 volunteers organized in about 800 units to improve health and safety of their communities. The MRC trains, recruits, and activates volunteers to support community health and safety during emergencies. This is, like I talked to you about in the case study, really helping supplement staff for medical and health operations during emergencies and planned events. It's a pre-vetted system, so we do not have to do that in the time of the fire, the flood, the infectious disease. You guys are ready to go and deploy to emergencies, especially with trainings like these. Provides medical and behavioral health support at shelters, again, those points of dispensings or pods, and community sites. You guys also assist those CBOs and access and functional needs partners, those trusted partners in our community who already work with special populations and addressing access, communication, and mobility needs for at-risk populations. And helping conduct community outreach, education, and preparedness activities before and after a disaster is a great way to use MRC volunteers. And community-based organizations. Who else we have on this call? These are local organizations that serve vulnerable or specific populations on day-to-day basis. They can also support this during an emergency and after emergency. They provide that culturally competent and accessible services to the communities they already serve and beyond. They can help us disseminate information through those trusted partnerships and connect clients with shelter, food, medical care, and recovery resources. So it's a great hub to get resources out through these community-based organizations. Advocate for the needs of underserved or at-risk populations. If you serve a very specific population, you're going to know more than I do about that population because you work with them day in, day out. So when their needs change, you have the idea of what those needs look like and can help support people like me at the public health department, or maybe the emergency managers, or whomever you may be supporting for this emergency response. All right, so let's go over the Medical Reserve Corps and community-based organizations coordination. Here you are going to see what may look like a very complicated activation process for you, but let's break this down to make it a little less complex. So we have activation triggers. This is saying there's an emergency happening, either by emergency declaration or by obvious, you can tell there's an emergency happening. There may be a public health or EOC request saying, hey, we need to respond to this emergency. The MRC is going to activate their volunteers through either Everbridge or Dravari, whichever system your MRC uses. We will also be activating disaster healthcare volunteers at that same time, depending on the community you are serving. These activation systems will then reach out to those medical reserve coordinators. Those medical reserve coordinators will say, hey, we need medical reserve volunteers to deploy. Here's where we want them to deploy. You go and respond, and then we demobilize. So this really kind of talks through that process. It gets a little tricky because a lot of times we're saying, hey, we need folks who are available. We're working with those medical reserve coordinators at that same time who are sending out those activation notifications. So I got a little bit crossed over there. All right. Why is this coordination important? I think we've talked about this a little bit already today just by showing that case study, but it helps with resource use and targeted support for people who have those access and functional needs. We need you to come out and help make sure people are taken care of where they are at the time. Reduces overall duplication and confusion during the activation as well, and helps us build trust through pre-established relationships. So that's why the coordination between MRCs and CBOs is so important. And then identifying partner roles. So really getting to know the people who are in this room. The best thing that you're going to learn is really who people are and what their capabilities are to support their response. Maybe this person's done 20 different shelter responses before. That's the person you want in the shelter. Maybe this person has some public health, education background, and they can help with outreach or some translation or other health needs. We also can develop contact trees and communication protocols to help with coordination and establishing who and how do I put resource requests through where I'm at. I may be in Monterey County on a regular basis, but I'm going up to Butte County to respond. How do I put the resource through when I'm a part of your MRC? How does that work? And then just conducting those joint trainings and drills to help support that and really practice. All right, some roles across mass care. Here we're going to talk about just the community-based organizations' roles. And I feel like this is a little duplicative, so I'll go over this kind of quickly. Staff and support shelter, particularly with services for children, elderly, and people with access and functional needs. Again, trusted partnerships, knowing what you know about the vulnerable populations or populations you serve. Helping distribute water, food, and clothing to affected populations, as I talked to about these being hubs and easy pathways for people to go to their trusted buildings that they typically go to or areas they typically go to, and help track and reunite separated families. If these are clients that you already have, you may have additional resources to help support that, including missing persons reports when we have major events such as an earthquake or during fires. The medical reserve can help support medical triage, first aid, basic health screenings at shelters or other reception areas. They can also help us provide behavioral health and psychological first aid to evacuees and responders, especially those who already are vetted through that process and have this experience. And then coordinate with community-based organizations. So communicate together and help understand what are the access and functional needs partners to help ensure that we are getting people the resources they need for full accessibility and inclusive care. Operational coordination. This is just making sure CBOs, I'll start with them, are providing communication with the EOC or volunteer organization leadership, and really coordinating together, sharing situational updates about community needs and resources, and participating in coordination calls or meetings to align efforts with your government and community partners. This should also be supported with who activated you in the response, whether it's the EOC, the DOC, and there should be a very formal reporting structure there that follows the incident command system. And then MRC can provide situational updates and field reports to inform that common operating picture, and then again, just work alongside those partners. Right, roles across health and social services, CBOs, again, the same thing, being those trusted partners, helping assist with referrals to healthcare, addressing the unique needs of those access and functional needs populations and beyond. Medical Reserve Corps, delivering public health education, outreach, disease prevention, can help with continuity of care for displaced or medically dependent individuals, and assist with health recovery and community resilience initiatives as well. Access and functional needs. I think we've touched on this quite a bit already, really just being those CBOs, being those trusted community networks and communication channels, offering language access, cultural competency, and disability advocacy expertise. Highly important. Identifying unmet access and functional needs and coordinating with EOCs and volunteer organization leadership. We have definitely used folks who use a wheelchair in a mass care shelter and ask them to wheel around through the aisles to make sure that they are able to fit and turn the corners and go through the doors. Highly important, and has been one of the most beneficial uses of resources. And then we know that people have the accessibility that they need within that shelter system. Medical Reserve Corps. So again, just providing those tailored access and functional needs support through medical, behavior, and public health, assisting with identifying where do we get some of these medical devices, durable medical equipment, medication for continuity needs, and then working with CBOs to assess and document access and functional needs requests during an activation. Helps us with lessons learned so we know how to do it better next time. All right, so this is where our first recording ended. And so you may see a quick splice in video at this point. So you will go ahead and go to the original recording at this time. We appreciate you and hope you have a wonderful day. Thank you.
So in terms of recovery, a lot of times this phase gets sometimes overlooked, although this phase is as important as all the other phases, especially because recovery really lasts for weeks, sometimes months, and sometimes years. And most often, the access and functional needs become more visible after the immediate emergency ends. And so your responsibility under recovery would be to maybe conduct regular check-ins with those individuals, offering them support, or maybe sharing any unmet needs you're seeing to help ensure that individuals' needs are not slipping through the cracks, for example. You can even support during recovery by maybe helping community members navigate, for example, the assistance programs that become available in times of recovery. And so these are really important elements that you need to focus on under recovery. And lastly, under that bullet, which is it's very important to bring your perspectives into the after action discussions, because this is where you can share all the issues that have surfaced and whether your activation or your interaction with those individuals, and bring them to fruition with those emergency managers to really further strengthen their future plans and make them more inclusive. So I know we talked about communication, and I really want to emphasize the importance of communication, because the way we communicate really helps determine whether people understand the message that we want to relay and can act on this life-saving information. And for communities like, for example, access and functional needs, accessible communication can literally be the difference between safety and isolation. Because if they're not receiving those information, we are automatically isolating them from safety. And so the first principle I would say under communication is making sure that any alert and warning message or any type of communication you're trying to relay is available in multiple formats. And that's because there is not like one single method or communication method that reaches everyone. Obviously, we all know that people absorb information differently. Some people may prefer, for example, written information, like when you receive maybe emails or flyers or alerts using your phones. Other may prefer, for example, verbal communication, where they hear the information over the radios or the community briefings, for example, or even visual cues like pictograms, infographic, caption videos. And so this is why it's very important that when you're trying to relay information to these communities, that you're using multiple strategies and multiple format, or even combine them all into one strategy. The second principle is using plain languages and translation. And a lot of times we tend to use technical terms or technical terminologies. For example, English is not my first language, and it's actually my third language. So although I speak it on a regular basis, a lot of times if I'm faced with a terminology that's very complex or that's more technical, I may not understand the intended meaning. And so that's why when you're relaying the message, obviously there's a lot of people like me whose English is not their first language. It's very important to use plain language, especially in times of emergencies where you're already stressed that you've received this message. So making sure that this message is as plain as possible is very important. And so for CBOs, this is an area where you would shine, because you already know the dialects, the tones, and the terminologies your communities respond to. And so that's why it's very important to also provide the messages in multiple languages as well, to make sure that your messages are reaching the full community. Lastly, on that bullet point is incorporating accessibility tools like captioning, sign languages, pictograms, and multilingual hotlines. This ensures that people with maybe hearing, visions, and language barriers receive the same timely information as everyone else. So for example, you can add ASL interpretation. I've seen it in the chat to a press briefing, or ensure graphics have descriptive alt text. So these kind of additions really make it or break it for a lot of people, where it's very important to incorporate them to help the message reach as many people as possible. So we can move forward towards this inclusive preparedness tool. So we prepared a couple tools for you all that are very practical tools that can help you integrate inclusion into your everyday preparedness and response operations. So first, we can start with the volunteer emergency plan. I'm dropping that in the chat right now. This plan is more specifically for MRC volunteers to think through their own readiness, and how basically how you would communicate or deploy or integrate accessibility into your assigned role. The second thing is we have the access and functional needs go bag, which is also in the document that I just dropped in the chat. And this is designed for everyone to use. It really includes assistive communication and sensory support tools that you can prepare ahead of time or ahead of an emergency, especially when you know that you will be in a position where you will be servicing or serving individuals with access and functional needs. So having these accessibility tools would be very helpful in times of emergencies. So really advise to take a look at these two documents as they are very essential for the response. And that really concludes everything I wanted to cover under this session. And now we're going to dive into Q&A, and I'm turning it over to you, Trey.
Thanks so much, Lena. Folks, we have a panel of a couple speakers who are going to go through some interesting and compelling points and presentations. And all the while, we'll have the opportunity for Q&A through the chat function, and we'll pause as needed to address any questions. But I first wanted to address our panelists today, who you can see on screen. We have speaking first, Susie Castoria from San Mateo County Health. And after that, we'll hear from Josh Sullivan, who will speak on a couple different topics related to Medical Reserve Corps and, of course, the role of community-based organizations. So with that, I'd like to go ahead and invite Susie to go ahead and start with your presentation, and we'll let you take it away. Thank you.
Great. Thank you very much. I don't know that I'm an expert for this, but I've been working with the San Mateo County MRC for a full 9 months. And I've been working with our CBOs, a number of them for a number of years because I'm active in my community. I think one of the things that is most important in terms of CBO partners and partnerships is to know who people are. We've gotten so much information today at a high level of what we should be doing and how we should be doing it, which is absolutely worthwhile and fascinating. But when it gets down to the emergency, Jessica can probably tell us, if you know the person's face, you know what they do, and you know what their resources are, you can pick up the phone, call the right number, and get the information or the walker or the whatever. It's really important to get together and know who your neighbors are. To do that in San Mateo County, we are actually running a pilot for our MRC that only includes the coastline of the county. So we have 36 miles of coastline, approximately 300 square miles of geography. It includes 2 whole incorporated cities and about 150,000 people, many of whom live out the dirt road that you turn onto at the signpost that used to be there, but it fell down. So giving directions, finding people, it's a little bit more of a challenge than, say, San Mateo City, where you turn left on 3rd Street and it's the 4th house on the right. What we're doing to work with our coastal community is we are having quarterly meetings that involve not only our MRC members, but anyone who would respond to or be looked to for information in an emergency. So we reach out frequently to the farm worker advocates. We reach out frequently to the senior advocates. We reach out to the CERT members, anybody we're going to be working with. We get them together in the same room. We feed them. Our next training is going to be ICS in the EOC setting, something that everybody's just flocking to. But I think it's really important that that's your first goal, is get people together in a room and talk to them. The other thing that was brought up here frequently was that it's the EBOs who can identify people with access and functional needs. This is certainly true. And functional needs include people who can't get out of their homes for whatever reason. If you don't have a car, or if your roads flood, you're in that group of people. If you don't speak English, you're in that group of people. If you happen to be in your 3rd trimester and you're a marathon runner, Well, if you're in your third trimester, you're in the group of people with access and functional needs. Most shelters are not set up as delivery rooms. So these are the people we have to identify, we have to work with, we have to have translators on hand, because we recently did in San Mateo, well, in Half Moon Bay, we did the first aid booth for the Half Moon Bay Pumpkin Festival with only, 150, 200,000 of our favorite friends. And the first thing that went down was the Wi-Fi. We had no translation services on our phones. We needed to have someone in the room when the bee sting came in and they didn't speak English. So luckily, it all worked out well, but we'll certainly be looking to all of our CBOs to help us out in any emergency. The other thing we have to identify is who can teach us appropriate cultural respect. Because I cannot tell you what to do if I'm saying something that insults you, you're not going to hear me. So cultural respect is very, very important in access and functional needs. The other thing, which is kind of jumping around, I realize, and I apologize, is for the disability community and anyone who's a pet owner, the question of, is this a service animal, will pop up. Service animals are allowed in all shelters. There are two types of service animals. There are dogs and miniature horses. And in California, there are now rules where shelters or areas must identify at least one shelter per town that allows family pets. So if you're putting together even an exercise where you're going to be doing evacuations, you should consider the fact that you need something to do with family pets. And you should be able to identify the difference between a service animal, a support animal, and a family pet. It's really important to know those, and the ADA regional offices have excellent resources for that. There are excellent resources for things like on the coast, we have the large animal evac group who can help you get your horses, your pigs, and the 2 llamas that live here safely evacuated. We had to do that during the CZU fire. Recently, we did an exercise where we set up our alternate care shelter, sorry about that, which was a fun thing to do. And we realized how important our ham radio people are to communicate. So we got our ham radios and everybody was able to communicate to the EOC, and it was an excellent exercise. And the other thing, going back to CBOs, and I'm jumping around again, is that our senior centers have closets with durable medical equipment in them. Walkers, wheelchairs, canes, and they are an excellent source an excellent resource. So the other thing I wanted to bring out is that PDFs are not always screen legible. So if you put out PDFs for all your information, people who need translation services or alternate formats cannot use their screen readers to comprehend your information. And there are resources for that with the ADA as well. So I see that there's some comments about allergies in the chat, but I am not prepared to discuss allergies. That's something that the shelter managers need to figure out on an individual basis, where you can tell someone as you come in that you have a need to be away from animals or whatever your allergens are, and they can be dealt with at the time of the emergency. Okay, if there's any questions, I'll gladly answer them. And I apologize that Arjun's not here. He's out of the country.
Any questions for Susie, folks? Feel free to put them in the chat or come off mute and ask your questions if you've got them.
Hi there. I don't have a question, but Susie, I wonder if you want to talk about KEEP.
Thank you very much, Sandy. Sandy is from our senior co-siders, and the region I'm talking about, the coast of San Mateo County, we have our own group of people. It's called CEAP, C-E-A-P, Coastside Emergency Action Planning Committee, where we actually all get together once a month, CBOs, emergency response, harbor patrol. It's a great group of people. We've been meeting for over, I want to say, 20 years, Sandy. Yeah. First Friday of the month. And we have really been able to get to know each other through that.
Great comment. I think networking is so critical. I've heard this in many circles. Susie, is just half the battle is making sure you know who you're working alongside with and you have communications with other organizations way before something happens. Certainly to shake hands for the first time at the time of crisis is not the best. So that's great. That's excellent. Any other questions for Susie before I turn the floor over to Josh? Any other questions for Susie? Yes, Sheila.
I guess my question is, could somebody email me an address to whom I can send some resources that I can't quickly pull out right now? If I did, I could just rattle them off. But there are some things that I think that would be helpful to this group. And one of them is the I can do it, Partnership for Inclusive Disaster Strategies. Late last year or at the beginning of this year, came forward with a medical survey that a person can fill out on their own time and have all their stuff listed. It's good for their doctors, it's good for emergency planning, it's good for a lot of things. And you can put a copy of this plan in your file, in this survey in your file once you complete it. And then your doctors have it, and so does everybody that can have access to your record. And that means that you don't have to describe or explain things when there's some kind of crisis going on. It's all written there for them to see and read. And there's a couple other ones too that I would like to do. There's a game that Sadie Martinez of Colorado does that's called Have You Ever? And that game is so fun because it's fun, but it's also, by the end of it, everyone has raised their hand for one reason or another. And in each question, she is showing an access and functional needs. Have you ever left your meds behind or didn't bring enough of them? Have you ever been somewhere where you should have brought water, but you didn't? Have you ever been somewhere where your cell phone is running low and you're traveling? Have you been somewhere where you don't know the place because you don't live there, because you are just coming to visit someone you've only seen twice? Things like this. This is access and functional needs. It's a very broad thing, and it's meant to be broad to help people get what they need. It started out, I think, because people didn't want to say the word disability because everybody's so terrified of it. Well, I've had disabilities all my 54 years of life, so I don't have time for that. But the thing is that people need what they need, regardless of what they call it or how they view it. People need to get what they need to function and be safe. So this is the way that I think preparedness is a culture of, not a one-off. I think a lot of people here have that already, but it's important.
Great comments. Thanks for sharing some of those resources that you mentioned, Sheila. That's great, great information. We'll have to certainly look for that and point folks on this call to that. That's outstanding. Thank you so much.
We can
Okay.
also have we can also have you send those to Lena's email that is in the chat, and we will compile that together and send it out to the group. So any resources that you guys have, we're happy to send those links out.
I have that in the calendar invite. I won't be able to
Wonderful.
find it as quickly in the chat. Chats are
I
hard to
think-
get through for me.
I think we'll have it on the last slide too, potentially.
Very good. Well, our next panelist here to discuss CBO and systemic readiness is Josh Sullivan. Josh, please feel free to take away.
Hi, everybody. Jessica, pleasure to meet you in a different light. I remember last time we met was actually in the norovirus shelter at the campfire. So great to see you. So my name is Josh Sullivan. I have been an active in a variety of realms in emergency response prep and everything else, wearing a whole bunch of different hats in the last 10, 20 years. I've been actively deployed to 5 fires, a flood, and I served in our jurisdiction's incident command structure throughout all of COVID when I was actively working in the government. I now sit as the executive director of Full Circle of Choices. I do just want to very quickly shout out to, I know Ron, I think you're still on the call, one of my partners in deployment, Ron Haylog, I saw him on earlier. 2 of those fires out of the 5, Ron and I were out in the field together. And then, of course, huge thanks to all of our MRC partners in Contra Costa County and our Health Emergency Response Unit. I see that thumb up, Ron. If you want to unmute at any point and throw stuff in, you are more than welcome to. But again, my name is Josh. 5 fires, a flood, absolute geek. Have been around the block a couple times. I always like to start anytime I speak with, if you take one thing away from what I'm about to say, that one thing. Today, after hearing Jessica and Susie and everybody speak so eloquently, it would be invest today to build the capacity needed to be there for our community members with access and functional needs. Every single deployment that I've been a part of, I was concurrently deployed with our MRC partners. And using that social medical bridge between the 2 services, we were able to do a tremendous amount of good, including at one in Sonoma, we activated the National Guard in a shelter after being told that the fire coming over the hill, the local answer at the time from the deployed asset was hunker down and hope for the best. So again, like sometimes the perspective we can provide as CBOs and MRC partners is invaluable in the crisis itself, but especially as we get involved in systemic readiness. So the first couple things I'd love to speak about on this is thoughts on supporting systemic readiness. We heard it today, you hear it every time, align your alphabet soup. ARC means something completely different in the intellectual and developmental disabilities community than it does in the disaster community. Alphabet soup is so important. Register to our CBO partners, register your agency and your emergency planning. I used to do a quick training once a year with our MRC from the community side of the fence on binary communication and its importance in emergencies. If our MRC partners had one New Year's resolution, I would say get that annual training on binary and alternative communication on the books and partner with local agencies for that. Again, on that plain language, some of the work that I've done with Gerald and our Health Emergency Response Unit and local MRCs is we've actually used Myers-Johnson, PECS, and binary communication to distill some of the most complex medical algorithms that are used in these things called pods, points of dispensing, in a way that our health officers use as an aspect of universal design for other things. And again, it's that core perspective of our nonprofit or community-based organizations. We provide a valuable asset, and it's called perspective. So learn to actually thrive in that space. To our MRC partners, you guys are amazing. Come out and see what we do too out in the community, right? Get plugged in now. Get plugged in today. Partner with your, so we, after that, partner with your local OES and local health jurisdiction. So I saw Jessica, or we had a partner that was asking about that. Again, your local health department is a great asset. Constant can probably help aim you to spaces to find opportunities to bring your perspective and your subject matter expertise there. Explore to our CBOs and other individuals interested, explore becoming a deployable asset today. I've sat on both sides of responses, being out in the field and actually being in that thing called an EOC, as what's called a logistics section chief, which is about sending out assets, sending out people and stuff. And it's very huge, but oftentimes to do it right, I gotta put this on. It's just doing it is right, but to do it and have the paperwork in place, oftentimes it's really good to link onto FAST, link onto your MRC, have what are called MOUs in place before the emergency hits, because it actually helps recoup some expenditures. I saw somebody talking earlier about phones and other assets when they're deployed. MOUs help with that. Partner with your local MRC. I've talked about that several times. MRC is amazing. And again, though, oftentimes our MRCs are medically oriented folks, where CBOs are medically adjacent or socially based. And the partnerships that you can have there just will pay off in so many different ways. And I'm going to talk about a few of those. Join your county's Access and Functional Needs Advisory Body. Most counties in the state have one. If not, talk to your board of supervisors, and you'll probably have one very, very quickly, because it's an essential tool. Again, aligning with first responders on that alphabet soup stuff is really important, and bringing your perspective. So can I go to the next slide? One of the things that we've done at Full Circle this year is when FEMA did its huge, someone correct me on the terminology, the alphabet soup, because it's like I'm 2 steps away from it now, but they were doing the multi-agency annual something drill. It was a giant drill, right? And this year was decontamination. And I heard Jessica speak on DCOD a little bit earlier. I was lucky enough that I had a group of volunteers from my agency with a wide variety of access and functional needs come out and learn what moulange is, the disaster makeup and all that stuff. And these aren't real wounds in the pictures. These are actually folks getting made up before the event. If you could go to the next slide. And one of the things that came up was, I think there's a quote if we advance one more. Our local FEMA representative said the biggest takeaway just from people with AFNs being there was agreed that they didn't know what they didn't know. And in this case, it was how to actually start the decontamination process for nonverbal, non-ambulatory community members. And I wanted to take just a brief moment. Kevin is in this picture. Kevin, did you want to say something about the importance of this or what you took away? If you want to unmute, I will stop talking the second I hear your voice, man. But again, Kevin is a person who uses adaptive and augmentative communication through an eye gaze Dynavox. And he's texting me right now. Probably wanting to run me over for throwing him under the bus here. But again, that concept of, okay, you remove a person's DME. If you don't have the day-to-day functional skills to bridge that gap, you could have some pretty terrible health outcomes. So again, like New Year's resolution for all MRCs throughout the state, binary communication skills. Hey, Jess, I'm picking on Jessica because she's at the top of my list here. Hey, Jessica, can you say yes or can you say no? How do you say yes? How do you say no? And then doing a training based on that. That's for some of our community members that use adaptive and augmentative communication. When we separate or teach. Oh, there we go. Go, Kevin, go.
Can you hear me?
Yes.
During During the drill last June, I was completely ignored. I had my communication device on 100%, and I was still ignored. Additionally, I went to the hospital for an emergency, and when I had the doctors working with me, no one would try to communicate with me, and I was alone for 30 minutes. They gave me meds. I'm on meds that can't mix with each other. I didn't know that my meds were communicated. I was freaking out. I knew what I was on but did not know that my doctors knew. I did not see my red folder which had my meds and my diagnosis. I didn't know that the paramedics had already communicated with my doctors about what I was taking. My caregiver was refused for 30 minutes before she could come back and give them my med sheet.
So again, that opportunity for systemic advocacy and systemic readiness, and really, really realizing that if we separate folks with, I think, again, like Jessica, I could just keep throwing you out of the bus. That concept of, Kevin, I'm picking on you. You live an amazing life of quality choice, everything else in the environment that you've built. Like I know I've known Kevin for a few years now, and we were lucky enough to support Kevin. You take someone out of the environment with the stuff that they need, and we're already, as an entire community, facing an uphill battle. Um, and again, to our other partners on the phone, if I'm of a certain age now, if I don't have my glasses in an emergency, I now have an access and functional aid. I'm not going to be able to see a doorknob. So again, the situation can make a huge, huge difference in when and how and what type of support or help you may need. Can we go to the next slide, please? Thank you, Kevin. Hey, and real quick, since you're still unmuted, Kevin, would you do it again? Or just give me a yes or no? Yeah, totally. Binary communication at its best. So again, perspective, perspective, perspective. Partnerships give perspective. This was one of the shelters that I was deployed to, and this was the only accessible stall in the shelter. When we arrived 3 days after the shelter opened, there was still a variety of there was a variety of stuff still there. We partnered with our MRC FAST and that thing called a SOC, not the socks you wear, but the State Operational Center. And we were able to deploy our first ever portable restroom to this shelter. And then the state started getting into that business because of that perspective. Can we go to the next slide, please? Probably one more advance. There we go. So in our universe, we engage in something every day called universal design, right? Folks, when you go into a space, I see Sheila saying, yep, universal design is a good thing. This was that same shelter where we found the restroom that wasn't quite accessible. One of the simplest things that we did when we first came in, I think this was a Ron and Josh special, is we came in and we knocked down the center bar on the doors so people who used wheelchairs could make it through the shelter front doors. Again, this is something that we live in that world every single day as your community-based organization partners, but it's something that you can start to get that perspective by partnering with us and getting that exposure. Next slide, please. So a super quick, brief aside on, this is kind of the bonus that I wanted to throw in, Spoken Hub partnerships. During the COVID activation, our county actually adopted this thing called Spoken Hub. I would encourage every CBO, MRC, and other partners to develop the relationships to be able to do this. It took what limited capacity we had in staff assets on the governmental side and amplified it exponentially because we allowed nonprofit CBOs and other qualified entities to become resource requesters and ask for the stuff they need directly to the Emergency Operations Center. And what that did is it actually let us actually go out as an asset to government and do that. Learn how to navigate resource requesting to our MRC partners, the ICS portion of that, the Incident Command System portion of that. I'm trying out the alphabet soup myself. And then definitely, if you haven't done a training recently on your ICS 214s, those actual activity logs, like just ingrained in your head, you got to do them. Spontaneous donations. I can tell you from the 5 fires that I was deployed to, spontaneous donations were a huge issue at each and every one. and our MRC being concurrently deployed with MRC FAST and other entities there, we often end up freeing up other staff assets by handling the spontaneous donations. And just don't be afraid to say no when people come in. I know people want to put their good where it does the most. There was a shelter that I was deployed to, and the day before we got there, it was a segregated shelter. So it was a special needs shelter not being integrated into the main shelter. They had accepted a very generous donation from a mattress like warehouse. We called him the Sofa King. He brought in like 40 or 50 memory foam mattresses, which were amazing for the gym floor. But unfortunately, after about 24 hours, folks that were there at that shelter didn't have the durable equipment and the disposable materials for their bowel and bladder care. So we ended up having a hazmat situation as the mattresses became contaminated. Last thing on this is integrated versus segregated shelters. If you ask me, nothing about us without us. Um, every shelter should be, universally designed and be able to meet the needs of the entire community. Next slide, please. So again, as MRC and CBOs, we should be wanting to bridge what's happening in that left side of the screen. That's my county's home EOC over to the right side of the screen, what's actually happening out in the field. And again, partnerships right now are the way to begin to do that. So I think that's my last slide, and I'm absolutely open to questions, comments, or anything in between. Oh, I
Great
see Ron.
information. Thank you so much. There we go. We got one. Ron.
Got one. We got Ron, who slept in my truck.
Josh, really quick, I just want to say thank you. It's so great to see you again.
Nice to
And
see you.
yes, I remember that day when we came in there about the mattress, and that was an eye-opening experience. Hey, I just wanted to ask you a quick question just about the MOUs that you had mentioned, because again, it's some things we know that we don't know what we don't know, and for CBOs, you're a CBO. We're all looking at the day-to-day operations of just trying to get through and get funding done to try to figure out what we can do during a disaster. We always tell people, CBOs, get your continuity of operations training done first. That way, you can be established. But then when you're trying to establish an MOU with the government, how do you go about that and saying, these are resources that we can help you with, but then, and I love what you guys are doing with Contra Costa County, that you can go straight to the government and get those resources. But, is there a template or something that you can offer or suggest
That's a great
that we can go
question,
to?
Ron.
What's that?
So that's a great question. So Gerald, I know you're on this call. We'll table that. Let's have an aside conversation. My advice as a CBO to another CBO: start locally, right?
Yeah.
And that might not even be your county. That might be your local city jurisdiction. And get them in place. For us, I think, Ron, our biggest barrier to activate in support is liability and liability insurance. If you have your MOUs in place that allow you to be a DSW and be deployed as an asset, which we talked about earlier, you're now then covered for these extra duties and potentially extra risk that you might not be covered right now in your home policy. But we could probably honestly talk to our constant partners about separate trainings on just that, actually codifying relationships. I can truthfully say in Contra Costa County, after stepping to the other side of the fence, there was I think it was the one you and I were deployed at, Ron, having those MOUs in place for mutual aid. Ron and I left one of the fires, came back, and then I immediately began helping recoup extra costs because those MOUs were in place. Oh no, Jessica has a question or comment.
And
Hopefully it's a comment.
that's the other part I was going to follow up on too, because I know that there's questions in the chat about funding, our federal fundings, and I know, and with an MOU, we can possibly get reimbursements for those costs that we do have. And I would always suggest that, just don't write up the MOU one time, but then always revisit it on a yearly basis to make sure they're still going to be constant. And and if there's any kind of, policy or however you guys do it where it's going to be constant and that it's just not, a one-time relationship, you're done and it's over with, but that's something that we can always go back to.
Yeah.
Sorry, Jessica, go ahead.
And Jessica, super quick, if I could just jump in on the other thing that I'm thinking about this as we're talking and some of the things Jessica said, some of the relationships to build are also outside of your area because oftentimes the most help you can do as an MRC, the most help you can do as a CBO is to be ready to be deployed adjacent to where you're at. Because oftentimes, like Ron said, we're doing day-to-day business operations here. And if we had an earthquake, fire, something in my jurisdiction or catchment, my primary role is going to be to help support the 350 people that my agency is mission tasked to serve. However, in the case where I was up, where I got to meet Jessica for the first time, that was us in a non-affected area deploying subject matter experts to help amplify her in her old role. Go for it, Jessica. Sorry.
Yeah, I just wanted to go back to the best way to start the MOU process is getting to know the people in the room and going and inserting yourself, making sure that the folks at the government, such as myself, who was in the public health department, knows a little bit about the CBO and what you do, and let them know you're interested in doing an MOU as a CBO. I really mix those ones up. So I think that is the best place is go and introduce yourself, let them know, participate in the exercises, the trainings, and get in the rooms with people because we, like you said, when you started it, you don't know what you don't know. So a lot of those resources that are out in the community, I had no idea existed until we needed them.
Exactly.
So
And
I think that's a great starting
And,
spot.
and Jessica, how strange that is, right? So you lived a life in the public health sector, right? I came from public health too, but the things we take as CBOs for granted every day, it's just what we do. And then every time I've been deployed, every time I've partnered, like when we worked on our medical algorithms using binary communication, right? Like distilling that down, that's just day to day for us, but you wouldn't necessarily know that because of your exposure, right? So getting to know people is the most important thing.
And Josh, I would be remiss if I didn't mention I'm the co-chair for Alameda County AFN. So if we have partners, we definitely want to partner. Even if you're in a different county, we still want to partner with you because we're making our way through this. We're trying to figure it out. And I know we've got members from Alameda County AFN on this training too. So we definitely want to connect. And then one last thing, independent living centers. If you guys don't know about the ILCs, it's one of the really, really good hidden resources that are out there that could help anything, any disaster in the nation. We can actually help and support with durable medical equipment. So last thing said. Thanks, guys.
And then villages real quick before I end my thing, email me. Let's chat. I can give you Kevin and I can come in and help teach binary communication or develop something that could be reproducible outside of our catchment for you. Not a big deal.
And can I get your email?
Sure, I'll put it in the chat.
Thanks.
Thanks so much, Josh. Great information, great interaction from those on the call today. Outstanding examples. And again, the message keeps going back to communicate, shake hands, get to know each other and so forth. So appreciate it so much. Moving forward, then we did plan to have a hot wash for today, but just due to timing, we're going to move past this. I will say though that we do have a participant feedback form. QR code is on screen. Lena is dropping that into the chat right now too. We're also going to have a thank you email going out to all participants today that will link you to that participant feedback form as well. It's going to cover the same information we were going to talk through today in the context of a hot wash. But this is really just to gather information about this experience, the information, the presentations, so for the betterment of future renditions of this information. So that said, please, if you haven't captured the QR code, just know that it will be coming to you in the form of a follow-on email after today's event. For next events, I do want to pass it back over to Lena, who will talk to you about the stipend for CBOs and eligibility information. Lena?
Awesome. Thank you, Trey. And again, yes, I emphasize, please fill the participant feedback form. Those are very important to incorporate your feedback into the after action report. So please do so. So now talking about CBO and the $500 stipend. So this project is part of the Bay Area UASI up to 12 exercises that we're conducting, and they are offering community-based organizations, each representative of community-based organization a $500 stipend for their participation in the seminar today. So if you are a CBO who whether attended the seminar, was a presenter, you are eligible for this $500 stipend. You need to be a 501c3 nonprofit organization. You need to be located within the Bay Area. You need to be in good standing with local government. And you must not be receiving any federal compensation for the same activity. And I do want to note that each representative of that CBO is eligible, meaning if there are 2 representatives per CBO, each one of them is eligible for the $500 stipend. The required activities are to sign a participation agreement with Constant, complete a CBO post-seminar feedback survey, which is completely different than what we just posted in the chat, and then submit your ACH form. Now, all of this information will be included within the thank you email that we plan on sending you afterwards. And I'll attach all the necessary attachments that you will need to complete. So if you are interested, please complete those and send them over to me by the 12th of December. And actually, please make sure you're CCing Jessica Driscoll. So I'll put all the necessary requirements and information in the email again. But again, the deadline is the 12th of December. So please make sure you take advantage of this opportunity because this was made for you. We can move forward, Trey, but before I move on, are there any questions about the CBO stipend? Okay.
I may reach out to you. I've never done one of these before.
Perfect. Sounds good. Thank you. All right. So next step is today we've conducted the seminar. We're going to conduct an after action meeting with the exercise planning team on the 12th of December. We'll also develop an after action report that really highlights what we've discussed here today, some of the considerations and the comments that you included in the chat. And that would really conclude this exercise. That's everything I have. I'm going to turn it over to Trey, and thank you all for attending today.
Thank you all for taking the time into participating in today's seminar, addressing how we serve, access, and functional needs populations during a disaster as Medical Reserve Corps, as community-based organizations. Great partnership, great conversation. The topic today on that note. Again, this seminar has been recorded and transcribed for future reference. And for those who are unable to participate today, the link to the recording will be provided in the follow-up email that Lena spoke of, along with the link to the participant feedback form, as well as information on eligibility for the CBO stipend. If you were unable to capture the QR code that's in the chat or on screen, again, don't worry, that link is going to be in the follow-on email. If you'd like the transcript from today's seminar, please respond to that follow-up email or otherwise reach out to Lena and our team will be sure that you get a copy. That said, on behalf of the Bay Area UASI Initiative, please have a safe and happy rest of your day and happy holiday season. Thanks so much. Goodbye.
Hi, everyone. Thank you.